Good evening. Good evening, everyone. Welcome to our ongoing Ethics in Healthcare Speakers series, where we examine important and controversial issues where medicine and society intersect. It's completely wonderful to see all of you here tonight. Thank you all very much for coming out on this beautiful Thursday. My name is Dr. Jim Hornstein. I am the chairman of the Bioethics Committee at the Community Memorial Health System, and it's my pleasure to moderate tonight's program. Let me begin by saying I'm really quite sorry we didn't pick a very interesting subject for tonight's discussion. Just by a show of hands, does anybody here have any feelings whatsoever about the use of marijuana in our community? Just a few, for those of you taping, just a few. So I think it's actually a very fair question to ask as we begin. Why should an ethics person host a conversation about whether marijuana is useful or is harmful in the practice of medicine? It's a fair question to ask. So why is an ethics person hosting this conversation about medical marijuana? And I'll give you two answers. First of all, in a way, why should we? Because Proposition 215 passed in the state of California in 1996. And in California, it became the first state in the United States to make medical marijuana legal for medical purposes. So I think it's fair to ask, why now make this a federal case? And I think one reason we make this a federal case is because it is a federal case. And let me tell you why. Although California doctors, myself included and my two colleagues to my left, are licensed to practice medicine in the state of California, our prescribing privileges are actually granted by the federal government, specifically the DEA, or the Drug Enforcement Agency, and the FDA, the Food and Drug Administration. And as of today, November 12, 2014, both the FDA and the DEA classify marijuana as a Schedule I drug. And for those of you who don't know what a Schedule I drug means, it means this. It means that the federal government says there are no indications whatsoever, anytime, any place, for any purpose for medical marijuana. Now, I'm sure all of you can then appreciate the ethical dilemma a California doctor may face in complying with both state and federal rules regarding recommending medical marijuana. No matter what you do, you are probably violating somebody's rule. But a second reason why medical marijuana is an ethics problem is frankly much more fundamental, and that is this. Just because something is legal doesn't necessarily mean it's the right thing to do or it's a good thing to do. And let me give you a very practical example. Everybody knows cigarette smoking is legal, right? Cigarette smoking is legal, but nobody would say that it's either the right thing to do or a good thing to do, although it's legal. So I think you get my point. Just being legal doesn't necessarily make something right or make something ethical. But what if somebody directly asks you, is taking medical marijuana the correct and ethical thing to do for that particular patient? And let me share with you, that is exactly what happened to me twice in my medical office this month. The first patient I'll share with you, of course, I won't tell you who they are, but this first patient is a 78-year-old woman who unfortunately has breast cancer and is constantly nauseated by her chemotherapy. Despite trying 3 commonly used anti-nausea medications, she still feels sick to her stomach every day. A friend suggested that maybe marijuana might help her symptoms, and as a patient of mine for over 20 years, she came into my office and asked me my medical advice. She said, "Doctor, what should I do? Should I take medical marijuana?" A very real patient in a very real circumstance with a very real indication. The question is, what should I tell her? Let me tell you the second patient that walked into my office this month. This patient is an 18-year-old female who's a junior at a local high school in Ventura. She's an 18-year-old junior. She presented to my office relatively commonly with a cough and a fever. Who hasn't had a cough and a fever this month? But when I asked her several other questions, and I asked her specifically, did she smoke, she actually started to giggle, and she said, "You mean cigarettes?" And I said, "Well, cigarettes or anything else?" She goes, "No, I would never touch cigarettes, but marijuana, well, that's a whole different story." And then she actually did something that had never happened to me before in my practice. She took out a physician's statement and recommendation, which she got based on California Health and Safety Code 11362.5, which she pointed out to me I'd never seen, which she got from a licensed physician in Los Angeles for $65 in a 15-minute doctor interview without any exam, and which she now uses to justify smoking 2 to 3 marijuana joints daily, including during school days. Now, when I asked her why she was using medical marijuana, she said, "Oh, absolutely, very simply, to treat her ongoing symptoms." And I asked her, what were those symptoms? And she said they were difficulty studying, and her mother said she was moody. Okay. Do you ever see that in teenagers? I don't know. I'm not sure I ever had that experience, at least that minute. She also went on to say that she actually liked the Los Angeles doctor who she saw for 15 minutes and plans on seeing him again when her prescription for medical marijuana, which she uses 3 times a day, expires in 1 year. So her prescription was for 1 year, or her recommendation. So I bring up these 2 cases to point out how common these kind of situations are in real clinical medicine in a lovely town like Ventura, but also to clarify several other important points about tonight's discussion. Firstly, our topic tonight is marijuana as medicine, and our focus will be on the medical uses, on the benefits, and on the risk of medicinal marijuana. Now, although I realize there is certainly some overlap, we will not be focusing on the legalization of marijuana purely for recreational purposes. That's a legitimate question, one we will not be discussing tonight. Now, I'm stressing this because the goal for tonight is not advocacy, either for or against, but rather education and engagement. Having said that, we are not an advocacy organization. We are simply here to engage you and to educate you. I do know enough, because I'm not naive, that some of you here tonight already have strong feelings one way or the other regarding the use of medical marijuana. And frankly, that's fine with me. It's fine that you have strong feelings. But rather than cheer for when somebody up here speaks your position or boo when they don't, I'd prefer you to try something different. So this is a little thought experiment for all of you that I'm challenging you on. If you stand against the use of medical marijuana, then I implore you, please try to listen to the current medical literature and see if you can at least understand why somebody else might reasonably support its use. And conversely, if you already support medical marijuana use, try to understand why other members of our community are really quite worried about its increasing use. And for those of you in the center, let's help together our fellow citizens appreciate this wonderful open forum where we can tackle controversial and heated subjects in a respectful and civil manner. And speaking of creating these amazing open public forums, I'd like you now to join me in thanking the Community Memorial Health System for providing this community with the opportunity to raise important issues where medicine and society collide, and hopefully to allow viewpoints to be heard, some of them yours, some of them not, insights to be shared, and solutions to be reached. Also, a special thanks to my dear friends Mike Ellenson, who's somewhere in the back. Mike is the Vice President at Community Memorial Health Systems Development and Marketing, and Mary McCormick, who's also somewhere in the back, I can't see her, who is the Marketing Manager. And frankly, to all of their great staff for their very hard work and great efforts to put together this program tonight. Ladies and gentlemen, will you please thank me for Community Memorial Health System. What they do is actually really terrific. Finally, I have one more thank you to give, and this has to do with yesterday. Yesterday was, of course, Veterans Day, and I'd like to begin tonight's controversial program, or potentially controversial program, with something which I think all of us can agree upon at least now. Are there any veterans here tonight? Can you raise your hands? Oh, quite a lot. Quite a lot. Quite a lot. Would you please stand? Ladies and gentlemen, on behalf of the veterans here, and frankly, all the other veterans in Ventura and throughout our country, please let's publicly thank these heroes for making all our lives safer, more secure, and very most importantly, more free. To all our veterans here and throughout our country, thank you all for your service. Again, thank you. And now, let's ask the question of the night. Is medical marijuana a good, safe, and effective drug for California doctors to recommend? Well, I guess we're done. If you could indulge all of us, we spent a little bit of time putting together this program, so if you wouldn't mind, humor us at least for the next 45 minutes or so to let us have our say, and then you can say yes or no again. Our first speaker tonight is a dear friend, Dr. Margaret A. Peterson. Dr. Peterson is on the active medical staff at Community Memorial Health System and is a member of the Department of Family Medicine. Dr. Peterson was born in Michigan and received her undergraduate degree in chemistry and biology from Western Michigan University. She also, thank you on her behalf. She also received a second advanced degree from George Washington University and is certified as a physician's assistant. She attended medical school at Ponce, Puerto Rico, and completed her internship and residency in family medicine at the Kern County Medical Center near Bakersfield. She is board certified in family medicine and is also currently undergoing certification from the American Academy of Cannabinoid Medicine. She is currently in private solo family practice in Ventura and is also a part-time medical director in a separate private practice of cannabis medicine. Ladies and gentlemen, please welcome to the stage Dr. Margaret Peterson.
Okay, first of all, I would like to start my little portion with just a quick review. A lot of people think they really understand marijuana, cannabis, pot, but in the medical side of things, we really don't use the word marijuana. We use the word cannabis. Cannabis basically represents a plant that is grown in many parts of the world, including California, obviously. It has been used as a medicine for over 3,000 years with a lot of historical evidence for use in pain, spasm, of course, I'm sure recreationally as well in their ceremonies, but the medical use is very distinct. It has been a medicine in the world up until 1942, including in the United States. It was on the United States Pharmacopoeia, which is the drug list of recognized medicines. And in 1942, it was taken off and declared basically not convenient for anybody and not a formal medication. It was not until 1970 that it was basically deemed illegal and on Schedule I up there with LSD and peyote and mescaline and some of the other psychoactive medications. But it has a long use, and Sir Oslo, what's his name? Oslo, it was one of the original internal medicine physicians, actually had used it with his migraines. He was kind of the god of medicine. That's it. Thank you very much. I knew that. Cannabinoids is a word that you'll be hearing something about. Those are active chemicals that are in cannabis plants that cause drug-like effects throughout the body, including the brain, the central nervous system, the immune system, digestive system, as an example. And these effects have been very well studied over the last several decades since the discovery of a system of receptors or of a whole system in our body termed the endocannabinoid system. As it turns out, the body has a sitting place for cannabis. And several years ago, there was an attempt to use that in the idea of the weight loss medication. It was a medication, if we know that cannabis will stimulate the appetite and give you the munchies and eat, well, if by blocking this receptor, you could lose weight. It didn't work out very well and never got launched because it was associated with suicides and homicides and severe depression. So it's one of the things that you think that you're doing a good thing by one receptor or by one action, but in fact you have a real distinct effect down the road that may be unintended, but nevertheless is there. This system was discovered in 1992. It was after I had graduated. And so I never learned any of that in my schooling. We now at Community Memorial Hospital is a teaching hospital. And I've asked several of the residents there, have they ever learned about this system in pharmacology or physiology? And none of them have replied yes. So this is pretty big. It's up there along with dopamine and serotonin, and everybody knows about Prozac and how kind of that works, but nobody knows about the endocannabinoid system, and it is much larger. So we have some teaching to do in that regard. Well, these are natural compounds called cannabinoids. They can be inhaled, they can be sprayed under the tongue, they can be eaten, they can be put on the skin. Several of these compounds have been synthetically developed in medications that you can write a prescription for and go down to the pharmacy and get them. Those have been basically studied with HIV patients and cancer patients for nausea and vomiting. This was in 1985 that Marinol came out, and it probably was effective at the time, but frankly, with my personal experience, there are a lot better medications available than cannabis for nausea from the pill, from the synthetic pill. That's not so with the plant, and we'll tell you why. There are 3 developed medications that are available. 2 are in the United States, and 1 is going through approval right now and is available in Canada and the UK and elsewhere. But one of the reasons why these medications do not work as well for other medical conditions is because it's not the whole plant. And there are other ingredients in the cannabis plant that has its effect. We call that the entourage effect. It's something it's coming along for the ride that has real specific value. You cannot take the 600 constituents of a cannabis plant and put them in a pill. What we're doing is extracting something and trying to make that work. And sometimes we know that when you do that, you lose the effectiveness of the whole material. That's one of the reasons why patients come and they say, well, I've tried my Marinol, it just doesn't work the same, what can I do? The top 6 conditions in a recent study for using cannabis were pain, sleep, nausea, arthritis, ADD, and migraines. That was what the patients were requesting it for, some study. I will add, as an additional part of that some of this, or much of this, is acting as a harm reduction agent. meaning its use sometimes is replacing more harmful things. We have growing evidence associated with decreased tobacco use, just like the young lady says, oh, I would never smoke a cigarette. A cigarette will kill you, but cannabis is not going to give you lung cancer. It has been definitely associated with decreased alcohol use. And it is that effect that in another really rather large recent study was associated with decreased traffic fatalities. Not because you're not driving stoned or not impaired, it's because you weren't driving drunk. And drunk driving kills so many people and young people. So it was the replacement of that that was associated with it, which is a little skewed. So cannabis can definitely impair your driving, but the more important part was kept kids off the road that were drinking. And then it is associated with decreased street drugs. If you have cannabis available, the kids are not going to go to Xanax, which is the #1 drug in Ventura High School. I'm sure that you will agree, Officer. In states that have enacted medical marijuana laws, there has also been a 5% total suicide rate reduction. And it's about 11% in young adults 20 to 29, and an additional 9% in 30 to 39. But all total, it was about 5% less. And recently, in the JAMA article, several months ago, it was reported that in those states that had enacted the medical marijuana laws, there had been shown a 25% reduction in deaths from opiate overdoses. And that's not necessarily in people who abuse it. Those are in normally prescribed doses that have serious consequences when they're too much, or you forget one, and you're just inappropriately dosing yourself, or appropriately dosing, there is death. The best evidence for cannabis as a therapeutic medication has been shown in HIV-related symptoms. It has also been in ulcerative colitis and in Crohn's and multiple sclerosis with its spasticity. Neuropathic pain, which is pain that's coming from abnormal nerves, be it from neuropathy, from diabetes, or there's a pinched nerve, spinal stenosis, things that are from nerve in origin. And interestingly, hepatitis C. But that effect for hep C is in that those patients that were using cannabis completed their treatment, which is pretty tough for hep C, and were able to clear their infection because they were able to tolerate the medication. Many people fail to finish their treatment because they just can't take either depression or nausea or whatever. So by using cannabis, helped them and was able to achieve the ultimate goal. So it's not that cannabis helped their hep C, it helped them complete what they needed to do to clear it from how we know to clear it. The top current research has now been in the realm of post-traumatic stress, particularly with regards to the head injuries from our vets overseas that are coming home. It's been in the cancer world, where much of the cancer research with cannabis is in Spain. They're doing tremendous work on a certain kind of a brain tumor, the one that affected Teddy Kennedy, called a glioblastoma, and there's breast cancer work evolving. Right now, we have no way ever to say that cannabis in any way is a treatment for cancer, affects cancer, but we know that in the lab that these cannabinoids can stop cancer cells in test tubes, and they can improve the immune system. It's just that we can't say that by doing that, improving, we're doing anything with it. We can't make those connections first. But the excitement is there, and in many people who, when they're grasping at straws, they come to me and they want to use this instead of their traditional recommended medications, and that's terribly inappropriate. So the point of this is to be able to tolerate whatever it is they need to do to get well. And the third real interesting and up-and-coming research, of course, is in epilepsy. Everybody's seen the Sanjay Gupta piece, and I just came back from a conference in Denver, and it's just, the hype is unbelievable. But when you see and you talk to the parents of these kids, it's pretty amazing. There's a real niche that this really helps. And finally, there is really no known mortality from overdose. Cannabis is literally one of the safest medications in and of itself to a human being. You can't, partly, and I didn't realize that, it's because there are no receptors in the brainstem that makes you stop breathing, as in other medications. And so if you are sitting in a chair and not driving and not walking, falling down, you can take so much cannabis and all you'll do is fall asleep. You will not die. That is so not true with with many other medications. But side effects, there are plenty. And the side effects basically relate to the type of cannabinoid, which I'll just go in a second, and the strains. So for just a real quick review, and it's kind of above the topic here, there are two major cannabinoids that we're talking about, even though there are at least 100, 60 of which have become very studied. It's THC, tetrahydrocannabinol, and CBD, cannabidiol. THC is relatively better worked out and understood than CBD, but CBD has more of the application. THC, the problem with that, it's a fabulous medication, but it has psychoactive effects. Just like Xanax, just like Percocet, but it has a lot of benefits. Basically on stomach and appetite and pain and general relaxation. Of course, you're coming with it, the psychoactive work, which is the stone. It really limits the effectiveness of the THC. But the good news is one can develop tolerance to that. And so people who are doing work that's requiring large amounts of THC, there are ways to get people to tolerate that first. The CBD is the one that is causing all the excitement. It is the cannabinoid that does not have any psychoactive effect. It will not make you stoned. It is more your anti-inflammatory. It is like your steroid, a prednisone. It is anti-nerve pain. So it is, I call it, when I practice, it's basically your gabapentin. It's your Neurontin. It's trying to help the nerves correct themselves. And its use is really what's exciting in the MS world, multiple sclerosis, and the ulcerative colitis and Crohn's, because it's powerfully anti-inflammatory. And we also know that inflammation percolates underneath most cancers. It's an inflammatory state, and so there's part of some of the mechanism or how they're trying to figure out how this might be helpful. So if you are taking something that has too much THC, you're going to be stoned. That side effect, or sleepy, or bloodshot eyes, or something, you'll be gaining weight. If you have too much CBD, you really don't have much side effect. But there's the other part of these two plants, that is cannabis sativa and cannabis indica. Those two plants are structurally different. One's nice and tall, the other one's short. The sativas are up in your head. So think Jimi Hendrix, think sativa, because it's psychedelic, it's fairly up here. But the indica is Cheech and Chong. I try to use those because most people do that. It's the bloodshot eyes, it's the munchies, it's falling asleep. So imagine if you accidentally got some sativa with a high THC content and you took it at bedtime. You have palpitations, you have panic, you can't fall asleep, and you're pacing and you're wondering what that's about. So in the strains and the education is when you're trying to use this for a medical condition, if it's nausea, if it's a migraine, if it's pain, you have to work with the strains where you're going to feel it, as well as finally which is the cannabinoid that you're trying to work with. Are you trying to work with the THC and those effects, or CBD? So I wrap myself up here with that kind of preliminary, and I will say that I almost want to engage Dr. Hornstein on his patients, but I think we'll probably save that till the end, maybe? Is that okay? I think I probably ended up my time. Okay.
Thank you very much, Dr. Peterson. Our second speaker is also a very close and dear friend of mine, Dr. Tara Snow. Dr. Snow is also on the active medical staff at Community Memorial Health System in the Department of Internal Medicine. Dr. Snow was born in Minnesota and received her undergraduate degree in molecular biology from the University of Wisconsin at Madison. Go Badgers. Dr. Snow also attended the University of Wisconsin at Madison for her medical school degree and completed her internship and residency at the University of Colorado Health Science Center in Denver. She is board certified in internal medicine and is a hospitalist practicing inpatient internal medicine at Community Memorial Hospital. In addition, she is also board certified in hospice and palliative medicine and is currently the medical director of Oakhurst Hospital in Ventura County, in addition to serving with the palliative care inpatient and outpatient service at Community Memorial Health Systems. Ladies and gentlemen, please welcome my good friend, Dr. Tara Snow.
Hello. So when I was first asked to give this talk, I knew I had a gut reaction, as I'm sure most of you here did, about what made me think that marijuana wasn't a medicine. And I didn't feel like I could articulate it well at the time, and so I decided to start with, how do I define a medicine? And so that is where I started, because I am a hospice physician and palliative care. I believe in alleviation of suffering, and I have no doubt that marijuana is very useful in a lot of those situations, especially at the end of life. I feel I wouldn't have any hesitancy. If it makes you feel better, please use it in this time. So why did I still not feel that marijuana is a medicine? And so when I think about what a medicine is, it usually is a specific chemical, and it has a specific purpose. I know what I want to treat and the intended effect it's going to have. I know how it works in the body, how it's going to interact with other medicines, and then also I know what unintended side effects there are going to be and whether or not there's risk for dependence. A very simple example of this is Tylenol. We're all familiar with it. We know how to take it. It's used to treat pain. There's a specific dose. We know how often to take it. We know if we take too much of it, there could be risks to your liver. And in addition to that, there are interactions with some of other medicines that your physicians can counsel you on. So I started thinking about marijuana, and as Dr. Peterson pointed out, marijuana is full of a whole bunch of different chemicals, over 400. And there are more than 60 different cannabinoids. Some of them are thought to have the good therapeutic effects. Some of them, like THC, are thought to have the psychoactive component. And in every strain of marijuana, you're going to have a different combination of these chemicals. So the chemical composition is going to change from plant to plant. And in fact, when it's cultivated, a lot of different strains are cultivated to enhance one component or another. And so I think that's one of the reasons why I struggle with marijuana as a medicine. There are all kinds of strains out there, and the patient chooses which one to get. And that might be okay because they can find one that works for them, but there's no quality control at the dispensaries. So if Trainwreck becomes the popular form of cannabis on the street or wherever, the dispensaries can simply label whatever product they want as Trainwreck. There's no regulation regarding contaminants or production. You don't know if there's pesticides being used or how it's produced. And that gives me pause as well, because I don't really feel my patients would know what they were getting. Now, I agree with Dr. Peterson. It has been used for centuries to treat all kinds of different medical problems. I mean, it was used to treat venereal disease, leprosy, tuberculosis. I had a patient tell me today that he knew a friend who was cured of his cancer by smoking marijuana. What is interesting, though, is there's been no consistent physician consensus on what it does treat. And over time, it's usually replaced, even in historical times, by more effective or at least more consistent medicines that have a more consistent effect from patient to patient and without the sometimes unintended psychoactive effect. Now, what am I going to be using marijuana to treat? There is evidence out there for marijuana to treat a number of things. Neuropathic pain, definitely. Epilepsy, especially in children, is one of the newest things that they're coming out with and looking at. Spasticity with MS, I agree with all of those things. And glaucoma, that's probably the one that's known the most. But the evidence that cannabinoids are more effective than marijuana is just not out there. And for glaucoma, it is there, but you'd have to smoke a joint every 2 hours to get the sustained effect. And I don't think that's actually humanly possible. And when you look at getting a recommendation for medical marijuana, right now the indications seem pretty much endless. So marijuana almost seems like the new miracle drug out there, and you can use it for just about anything. There are a lot of anecdotes out there, and I've heard them. Changed my life. Nothing worked for me before. I got my life back. Marijuana is the only thing that saved me. And I appreciate the anecdotes and the case reports, but when we look at that emotional testimony, what we tend to do is focus on the positive and forget about the negative. When somebody believes a therapy is going to work for them, it's more likely to work for them. And if somebody believes a therapy is not going to work for them, it's much less likely to work for them. And this has been proven in placebo and clinical controlled trials. So I think I went too fast. And I think we need to take that into account. There's great value in cannabinoids, I have no doubt of that, but I would like to have clinically controlled trials so I know exactly what effect I can get. And when we look at what medical marijuana is being recommended for in California, 73% of the users are male, with the majority under the age of 40. And the primary reason is for obtaining is for generalized pain. And that wasn't listed in any of the indications I talked about. Neuropathic pain, yes. Spasticity, yes. Generalized pain, that hasn't been studied. And I kind of explained again why I went out of order, sorry. I hesitate to rely on treating with case reports and anecdotes. For the same reason, if somebody came into me and said, you know, tobacco is the only thing that keeps my anxiety down, no matter what, I need this, I'm not going to recommend it. And part of me is worried that the reason it works is not so much because of the cannabinoids, but because of the psychoactive effect in medical marijuana. When medical marijuana was first passed in the state of California, the amount of the psychoactive cannabinoid was about 6 to 9%. Since legalization, that's increased up to 25%, and the amount just keeps growing. So if the other cannabinoids are the more therapeutic form, why is it the THC is the one that's increasing? When I prescribe a medicine, I like to know what dose to give. A marijuana recommendation allows the patient to choose what strain, how often, and what form to drink. So whether they're going to use oils, whether they're going to use edibles, whether they're going to do inhalation. And beyond that, it doesn't seem like there's any limits to how much they can get. So are they sharing it? Where is it going? Patients can grow their own marijuana, they can make their own strain, and it's very unclear to me what each patient would be getting then. If this is okay for people to choose with marijuana, how to dose their drugs, Would it similarly be okay for me to say, I think you need an antibiotic, why don't you go down to the pharmacy and pick out which one works for you, and you decide how long and how often you need it? I think we would all agree that sounds a little off. And, I agreed with Dr. Peterson on a lot of things that she said. But when I think about getting a prescription filled, I think we've all filled prescriptions, right? You get something from a doctor, you go to a pharmacy. There's maybe a short line, not a long line. There's usually not a lot of excitement related to it. The pharmacist gives you the prescription and tells you, okay, this is how you take it. These are the side effects you need to look out for. When filling a medical marijuana recommendation, it's really patient choice how they decide to do it. And so I wanted to share this video with you about patients filling their medical marijuana recommendations. Sound?
Seriously, high times in Boyle Heights this week in the city's first marijuana farmers market opening at the California Heritage Mart. NBC4's McCullough Medina is there live where the line for Indo was wrapped around the block. Mac, what's up?
Yeah, these lines are crazy. They have been here since early this morning, and it's taking folks an hour to an hour and a half to get inside. Take a look at the lines. Yeah, you mentioned it's wrapped around not just this block, but it's wrapped around the next block as well. Once these folks actually get inside, they're going to run into about 20 to 30 growers. Let me take you to video from inside to give you a better indication of what that looks like. Organizers say it's similar to other farmers markets we've seen here in LA, direct access to produce, but in this case, the produce is medical marijuana. Now, it is not open to the public. You have to have a medical marijuana card even to get inside the building and purchase the product. Organizers are checking cards, calling doctors, checking IDs, and running licenses through the state's medical marijuana program database before they're even allowed in. We talked to one of the growers who says he was amazed by the turnout.
So far, it's crazy because I think nobody's ever seen the likes of this before, neither farmers nor people buying. So right now, I'm just sort of overwhelmed with the amount of business we're getting.
Yeah, they are getting a lot of business here. The organizers of the farmers market says this is the first time it's happened in LA County, and they're going to decide whether or not to continue based on the turnout. If they base it on today, on day one, they think they'll continue to do it every weekend here in Boyle Heights. We did talk to LAPD a short time ago. They said everything is on the up and up here as long as they continue to sell to those folks that are legally able to buy medical marijuana. Of course, everyone is keeping a watchful eye on what is happening here in Boyle Heights. We're live in Boyle Heights. I'm McCullough Medina, NBC4 News.
A little different experience than taking a prescription for a blood pressure medicine to the pharmacy. So going back to, okay, how do I reconcile this in my mind? I do believe there's value to cannabinoids, but I don't believe marijuana is a medicine. I already talked about the lack of production control and quality, the risk for contaminants and fungus. And I actually found, reported in the National Institute of Drug Abuse in 2001, as well as the European Respiratory Journal in February of 2008, that there's a significant risk of getting lung cancer. So smoking about a pack of cigarettes per day is going to increase your risk of lung cancer by 7%, and smoking a joint per day increases lung cancer risk by 8%. According to what I saw. And I know Dr. Peterson had contradictory data towards that. There was a recent article in the LA Times about how long-term use definitely decreases brain volume. Immediate use will cause tachycardia and can be problematic in people with heart disease. But again, as Dr. Peterson pointed out, it's going to depend upon the strain, and so you have to be wise and choose it. But I'm not certain, since the patients can choose what they want, that that's always happening. And it obviously impairs performance of complex tasks. I doubt anyone would argue with that. Marijuana contains 50 to 70% more carcinogens than tobacco smoke. So I'm worried about the inhalation effect, and that's long-term use, especially in these young people who are starting out at such a young age. So again, worrying about the side effects, you have to weigh the risks and benefits of using a medicine before you can recommend it. THC is addictive, and you can get a withdrawal syndrome. It lasts only for about 2 weeks. 9% of adults who start using marijuana are going to develop addiction, and that's about the same percentage as people who start drinking alcohol. I was surprised to learn when I was doing my research that there actually is a Marijuana Anonymous that's been started. There are 12 branches in California for people who have had their life adversely affected by excessive use of marijuana. How does it interact with other medicines? Well, because of the way medical marijuana has come into our society, there haven't been a lot of good studies to look at that. And so we really don't know if it's having an additive effect, a negative effect. And so I don't think we can give good advice to our patients on how it may affect the efficacy of their other medicines. So in conclusion, for me, a medicine has a specific chemical. And Dr. Peterson mentioned the entourage effect. I still want to know what that entourage is and where it's going. What am I treating? Am I treating everything, anything the patient wants me to treat? Can I devise a better strain of marijuana that is really going to focus on spasticity, or is it just whatever strain they feel is effective? I know it works through the cannabinoids, but how specifically? What is the duration of action? What's the appropriate dose? What's the appropriate route? Is there a safer way to do it besides inhaling? And what are the, definitively to know what the long-term side effects and risks are associated with chronic marijuana use. I really do believe that cannabinoids have incredible potential to advance medicine. A large number of our current pharmaceuticals are plant-derived. But my concern is that the way we've allowed medical marijuana to come into use, it's inhibiting all of that research, and we're not finding all of the uses and the best uses and the most effective ways to use cannabinoids. Emotional testimony and personal opinion shouldn't dictate medical treatment. I can't imagine having a chemotherapy or an antibiotic go in front of the voters and say, should we make this legal or not? We usually go through FDA trials, clinical trials, weigh the risks and benefits so that we can minimize harm and maximize benefit. One of my biggest concerns was the push behind medical marijuana and even recreational marijuana now more financially driven because it is such a huge economic boon. If you want to open up a medical marijuana dispensary, there are YouTube videos that will guide you through how to do this. I did not look, but I'd be highly suspicious to think that there were YouTube videos on how to open a regular pharmacy. The entire economy of Mendocino County now in California is pretty much dependent upon medical marijuana. And that's concerning as well. And then looking at all the press about Colorado and Washington, what's going on there with the revenues and how much they made in the first few weeks. There's huge bidding wars going on now, I believe, in New York. It's either New York or New Jersey, because they've recently legalized medical marijuana, and they're only going to allow 5 dispensaries. And so you can imagine the political shenanigans that are going on in order for one person to get that special dispensary license. Those are my thoughts on it, and that's how I feel. I wish we would do appropriate research to really maximize the benefit of the cannabinoids, and I look forward to a robust discussion. Thank you.
You know, I was just in Target a couple of weeks ago, and I'm grateful I didn't go to the Target in Boyle Heights after seeing that it was a lot easier in and out in the mall. One of the other benefits of living in Ventura, I guess. Our final speaker is the Chief of Police for the Ventura Police Department, Chief Ken Corney. Chief Corney was born on the East Coast, but has lived in Ventura since 1970. He received his AA degree from our own Ventura College and his bachelor's degree in journalism and public relations from California State University at Long Beach. He has a master's degree in business and organizational management. We're the alumni. We'll be doing some fundraising at the end of this. Where was I? Business and professional organizational management from some university, and is and is also a graduate of the Senior Management Institute for Policing at Harvard Kennedy School of Government. Veritas, anybody here? All right, okay. He has served with distinction with the Ventura Police Department for 28 years and has been police chief since 2009. Ladies and gentlemen, please welcome to our stage Chief of Police Ken Corney.
Well, good evening. So I want to start off with how I got here. I think back in July, my phone rang. I was in my office, and I think I actually picked it up, which is, I didn't recognize the number. It was somebody who identified themselves as Dr. Hornstein and invited me to participate in a discussion on medical marijuana, the ethics of medical marijuana. And my immediate response was, who is this really? I thought it was one of the old retired guys playing a joke on me, or one of my peers at work thinking that would be funny, so I hung up. Phone rang again. This time my secretary picks it up and said, there's a Dr. Jim Hornstein on the phone, and he's wants to talk to you about speaking. And I said, let me Google that. I'm joking, but sure enough. So I was actually surprised to get the phone call, and I gave a lot of consideration to this, as the doctor knows, and thought about what my role in this discussion is, and what value I could bring, and then again, I think the immediate assumption is, well, the police are going to come here and tell you why not to do everything or do something that's illegal, and we're not. Law enforcement enforcing laws is a tool of policing, but policing is really about harm reduction and having a safe community for all of us to live in. So, and that's certainly my goal as police chief. So when I came down to kind of coming on what the topic I would talk about in terms of what were the ethics of medical marijuana, I want to address the dispensary system in California, and that came along with the passage of Prop 215. So I just want to go off by saying that I think the lack of any statewide health and safety standards has caused a pretty big problem for legitimate patients and their caregivers in California. And one example that I was told was a director of an emergency room services in a hospital in Orange County treats his epileptic daughter with high CBD marijuana oil, medical marijuana oil. So we talked about that and that treating kids with epilepsy. Okay, and this is a doctor in an emergency room. Okay, he obtains the CBD oil, then he sends it out to a private lab to make sure it's not contaminated or doesn't have high THC, remember the stuff that makes you high in it. So of course his medical background clearly benefits him in being able to do this, but there are a lot of patients, parents, caregivers and stuff who don't have those kind of resources and are kind of trapped within our system of unregulated medical marijuana in the state of California. And in other states too. There's just little regulation here. So while there's certainly professionals and knowledgeable dispensary owners and employees seeking to professionalize this industry and bring medical marijuana into legitimacy, Proposition 215 really didn't do a lot for that. There's no standards for medical marijuana, as I said, and dispensary owners and their employees don't even know much about that product they are selling. And could you imagine going to a pharmacy and getting a prescription and them saying, hey, what am I supposed to do with this? And there's no instructions. Dr. Snow talked about that a little bit. That doesn't occur at dispensaries. At least it's not required as a standard. If medical marijuana, if that industry in California were really aimed at legitimate patients and health, they would insist on professional standards and health and safety standards. And those weren't established in Prop 215 and have never been required in any of the dispensaries that have been opened in California. So I think until that's resolved, it will serve to undermine the legitimacy of medical marijuana, and especially in California to Prop 215. So now that I've talked about what some of my problems are, my issues are, let me talk about what I think could be done to improve the post-Prop 215 medical marijuana environment in California. Now, I want to preface this by saying my comments are not an endorsement of medical marijuana, or not an endorsement of the legalization of marijuana, or a gateway discussion into legalizing recreational marijuana. Just merely some thought-out perspectives that I've gained from my time as a police chief, but also my time in the profession dealing with other professionals who have examined this. First of all, we need to develop and implement a comprehensive framework for the implementation that provides local governments the authority to create and enforce locally driven policies to regulate medical marijuana. The Prop 215 passage created regulatory chaos. There's case law, nobody's quite sure what to do, state law, federal law, things like that. And it's created piecemeal legislation, and litigation was expensive for local government. So we need to straighten that out. Over the last year, there's been several bills that have come forward that have attempted to undermine or eliminate local control over these critical issues, such as municipal zoning, permit decisions, licensing ordinances that are going to be cast down on a statewide basis and not letting local governments and local communities make these decisions. These bills also ignore public safety concerns about promoting recreational use. They limit local law enforcement's investigation powers and fail to address diversion of the product for cartel activities or security concerns at dispensary. And of course, finally, they don't include any health or safety oversight that's necessary for all other medicines. So last year, the California Police Chiefs Association worked together with the League of Cities to co-sponsor legislation. It was Senate Bill 1262 that for the first time would have effectively provided some local control over medical marijuana dispensaries, would have protected public safety and create uniform health and safety standards for the distribution of medical marijuana. I want to talk about those real quickly. First of all, it would uphold current law and build on existing policies that provides local control for regulating local medical marijuana facilities. It would require local medical marijuana dispensary owners to secure all local permits and to obtain a state license. It would took measures to help prevent. It would prevent recreational marijuana users from having easy access to medical marijuana. Too many M's in there. For non-medical purposes. So basically, it helps reduce the shell game of people using the medical marijuana system for recreational marijuana use. And it would create stronger tools for the California Medical Board to monitor and regulate doctors recommending medical marijuana and make inquiries and audit doctors under specific circumstances that are believed to be violating or abusing medical marijuana recommendations. So I want to summarize what I feel here by just saying that I'm a police chief, I'm not a doctor, I've never been to medical school. I know very little or understand very little in terms of what a doctor does about the cannabinoids and from a medical perspective. But what I can tell you is from a perspective of somebody who's spent almost 30 years in policing and has seen the impacts of drug and alcohol abuse with lack of adequate control and how it devastates individuals, families, and communities. So whatever we ultimately do with medical marijuana, I think what's important is that we have it fundamentally based on 4 goals of a sound drug policy that I believe are to reduce the illegal use of drugs, to reduce the abuse of illegal drugs, and to reduce the harmful effects of those drugs on individuals and communities. There were 3 things. I think those are important fundamentals that we need to strive for in terms of how we move forward with moving forward with medical marijuana in our community. So thank you for your time.
You know, I think the chief was being exceptionally modest when he described our conversation. When I called him on the verge of harassment, I think by the time I got through to him, and we had what I thought was a good conversation that lasted more than 45 seconds, the chief, I think, acknowledged that every cell in his body wanted to say no to being in a public lecture on medical marijuana. And I think it's a testimonial to his strength of character and to his view of leadership from where he stands that he actually is here today to represent what I think is an important voice in the community. So I think, could we please... Or it was just persistent. I was not going to stop, so I mean, he had no choice.
Bought a car from you too.
Yes. So we're going to give our speakers just a few minutes to kind of collect their thoughts, and then we're going to go to answer some questions. While we're waiting, I'd like to ask you, would you like to hear two really dumb doctor jokes? All right, can we? All right, so these are bad, okay? So I'm disclosing that. First of all, recently I had a patient walk into my office who complained of being addicted to soap, but you shouldn't worry about him because he's clean now. I told there is truth in advertising. All right, and number two, recently I had a patient walk into my office who complained of being addicted to brake fluid, but you shouldn't worry about him because he can stop at any time. Do we feel better? All right. This very well may be my last moderating experience, so I'd simply like to take advantage of the podium. So now we're going to switch. We'll get to questions in just a minute, but thank you. We're going to ask a number of questions to our panelists. Hopefully we can get to as many as possible in the time allotted. And then, as our custom, we will allow each panelist several minutes to have their soapbox to complete our conversation. So the first question I have to any of our panelists, or all three, is medical marijuana the drug of choice for any medical condition? Meaning a patient walks in and you say, yes, I have the drug for you. This is the correct drug. Would you please state what that condition is?
My feeling is that the one condition that I think has really very poor alternatives is fibromyalgia. That is such an interesting condition that encompasses so much more than pain. There really isn't anything else, if you really understand this endocannabinoid system, that could be helped and is in fact helped a lot with cannabis, certain strains, certain cannabinoids.
I have personally never recommended medical marijuana, so I guess my answer to that would be no.
Some would argue that marijuana is less dangerous than alcohol or tobacco. How would you answer that? Chief?
It depends. No, actually, I think that's, I think there's certainly there's no scientific studies really to indicate that. I have read research and I've seen the cost of alcohol abuse being much higher than marijuana abuse, but of course, marijuana wasn't as widely used at the time of that study. So I think when you're weighing two bad options, I think that's a bad reason to do something. Well, it's not as bad as something else. Cutting off your fingers hurts less than cutting off your arm. Why is that a relevant argument?
How would you, to our other speakers, would you like to take a shot at this?
I was very surprised to learn that marijuana has the same rate of addiction as alcohol, and that there's significant risk for lung cancer. And so I lost my train of thought completely, but I agree with how eloquently it was said previously.
Repeat that question.
Dr. Peterson, let me repeat the question. I have not lost my train of thought. Some would argue that marijuana is less dangerous than alcohol and tobacco, two substances which are, of course, legal. How would you answer that?
I absolutely agree. It is absolutely less dangerous if dangerous means lethal. It is absolutely not lethal. Cigarettes are very lethal. Alcohol is lethal. I was saying that the risk-benefit ratio has to be considered. What is the benefit that you're getting versus the risk that you're getting? You have cigarettes are very clearly, what is the benefit of that? Alcohol, there have health benefits that are documented, and there's also a lot of problems with excessive use of alcohol. And depends on who's using it. Cannabis, there are people who probably shouldn't use it, but generally speaking, it's, I think, considerably less dangerous than either of the cigarettes or alcohol.
A question addressed, I think, to all three of our panelists. Is marijuana safe for children, adolescents, and pregnant women?
I'm going to answer that as a layperson and say absolutely not. I've read a lot of studies that talk about the effects of THC, marijuana, on the adolescent mind, and studies that talk about, when they first began use and what that does to their actual maturity, brain growth, ability to learn, and it's very detrimental. And so I couldn't disagree more or agree more that it is not good.
So there are a lot of questions in this world that are not cut and dried, black and white. And I do believe that there is huge potential for the current strain that's being explored for use with children with refractory epilepsy. I do not believe that inhalation of marijuana is an appropriate form of use. I do believe that treatment for epilepsy in children is probably going to be a great use of cannabinoids, but we haven't done the right research to make it as safe as it should be. And then otherwise, I don't believe it should be used in children, adolescents, or pregnant women. I can't remember the studies that were done in Jamaica or Haiti. You might know more about them in pregnant women where it's used a lot more often, but I do believe there were cognitive effects on the unborn child.
First of all, I'll just tell you, I'm a big lactation educator, doctor in this area, and it is concentrated 4 times as much in breast milk. So it's really depending, unless your child really has epilepsy or brain tumors, for which is actually some tremendous evidence, I highly discourage that. I did research for one obstetrician that asked me several years back how bad it would be for his patient who was pregnant in her first trimester, because she was in and out of the hospital with intractable throat vomiting. And she was really at risk of losing her baby. And I looked it up, and at the time it basically said, risk-benefit, losing the baby versus possibly using this, but it basically at 3 years of age, they could show perhaps some excess ADD, hyperactivity. Well, I think that the rate has got to be 50% in my teenagers that are hyperactive in my regular practice. It's just something else is going on, not that. So that was a complete risk benefit. I absolutely discourage it and anybody getting pregnant, trying to get pregnant, because there is no need. What are you trying to treat? Pain, epilepsy? I mean, unless there's something it's not recreational. So So that's breastfeeding, pregnancy, adolescence is a huge issue. I absolutely agree with everybody that it is the excessive THC, not CBD, on a growing brain really imprints it. And there has been legion of evidence. Remember, let me just digress. Remember, there are no studies that can be done on cannabis because it's not a researchable drug. You have to have something that's able to be scheduled down to 2 or 3 to have any research, because as long as it's stuck in Schedule 1 saying there is no medical benefit, there isn't any incentive for anybody to try to find some benefit. So the first part of that is it has to be rescheduled, you'll hear this talk, so that it can get to the point where somebody can do some research. Most of the studies that we have are preclinical, meaning they are in test tubes. They are in laboratories, and they know how things work. Then they move on to animals. What we have are clinical, anecdotal studies. They can be double-blinded about, that's a contrary. We have observational studies, I should say. There are people that do things, then we look and see backwards what happened. Just because where the basic studies are occurring with the National, NIDA, Institutes for Drug Abuse or whatever, are not ever meant to look at benefit. Every one of them is designed and funded to look at the detriment. So going to the one that about the lung cancer, Dr. Tashkin, who was the director of pulmonary medicine at UCLA in the 80s, was funded by NIDA and I think National Institutes of Health and he was funded to be able to identify is cannabis as dangerous or as cancer-causing as cigarettes. And a very elegant little study showed absolutely not. And the guy spoke to a conference for us and said, no, it causes bronchitis, it can cause cough, and it was all inhaled, it wasn't sprayed or edible at that time. And he said absolutely, it was very clear there was no there was no lung cancer. Not even. It's huge, and I have problems with that. A cigarette, a pack a day, only increasing at 7%. I would think 70%, but that's another whole story. But adolescents, getting back to adolescents, I digress a lot. It does not belong in adolescent medicine. Now, pediatrics. There is I was watching some work on the cancer, brain tumors, a couple of basically them are different brain tumors, and how they're dosing this is they have THC and they have CBD, and actually THC was just as important. It was a 4-to-1 concentration of THC to CBD, and in powders weighed out and given to the babies, and able to tolerate it. It's a dosing schedule, and they really work intensively with the parents. And this is what the dramatic CT, MRI changes are just shrinking these tumors away. And I wish that I'd had the name of the doc at UCLA that now is collaborating with this caregiver group up in Santa Cruz for the babies. They've had like 7 of them now. And they are it's on the internet. They're starting to get a movie, trying to get the thing completed, kind of like a Sanjay Gupta thing, but they don't have quite the money for the documentary. But the observations, how are these children progressing? And the one for the epilepsy. And these kids now have been growing about 2 or 3 or 4 years now, and I'm sure they're doing a lot of cognitive testing and the things that they do, and they're progressing very well. Once again, the risk of having uncontrolled seizures and the brain damage that occurs, you have to be weighing that with this. The risk, very probable risk of death in brain tumors and problems is very, very real. Countered against the possibility of cognitive impairment should you live.
Thank you. So here's a yes-no question to all 3 of our panelists. Should the FDA change medical marijuana from a Schedule I to a Schedule II drug? Chief?
Well,
we've got all day, Chief.
Yeah.
So.
Well, I want to say that I think that is a decision that needs more thorough research and not done out of emotion and not done out of politics and not done out of the concept that there's money to be made in marijuana and medical marijuana. I think there's some research showing that certain components of marijuana, CBDs, things like that, may have some benefit in certain areas, and I think there's the potential for that research moving forward. But my concern is that it opens the barn door, so to speak, for a use that it really isn't appropriate.
Dr. Snow?
Yes.
Dr. Peterson?
Absolutely.
Okay. A recent article in the LA Times claimed that there were more marijuana clinics and dispensaries in Los Angeles than there were Starbucks. Chief, will that ever be the case in Ventura?
Well, that is, again, a local decision. I think it's been before our council at least a couple times since I've been police chief, and council has opted for local control and as the rest of the cities in Ventura County, not to allow any dispensaries to operate.
Any feelings?
My understanding, because I attended several of those council meetings, the issue, because if you're going to allow a product to be used for the benefit of somebody, part of that is incumbent upon it to be able to be obtained. And there are some people, many people, who can't grow anything, and so must be able to obtain it somehow. Once I understood what was going on in the city, I think it had more to do with, not that they really didn't want a dispensary or a collective or a co-op there, it's they did not want to be charged with the managing of that. The city has enough to do. It does not need to be inventing the wheel and figuring out how to regulate something. So I think that there is some common ground. If ever a mechanism was developed, then city or county-wide, then perhaps that might be open, the conversation. Because I don't think, like, you're in charge of upholding the law and making things safe. If the law says that you can use cannabis, what has to happen is who's in charge of making sure that that is a safe way, either to get it, deliver it, to grow it. And I thought that was my understanding. That wasn't the city saying no. It was saying, we don't want that job, move on, because we have enough to do.
So I have a question. Is there anybody from the state here? So I think we can ask this question. Do you think the state of California has ducked this issue and dumped it on the cities?
Counties?
Yes. So, okay, we'll go on. I think, yes. So, Chief, and maybe to our other panelists, urine tox screens for marijuana can be done, and if you do them, they can be positive because the metabolites in marijuana can last upwards of 7, 10, 14, even 30 days. So, to the Chief, how can an officer document a DUI using urine drug testing when someone may have taken the drug 1 to 2 weeks earlier? How is your law enforcement pulling over people suspected of drunk driving and being under the influence of marijuana, given the fact that there were 2 recent articles published in the medical literature that states smoking marijuana increases your risk of car accidents by 2 to 2.5 times while intoxicated? So, Chief, given the fact that we have difficulty with urine drug testing for marijuana, how do we diagnose DUI in Ventura?
Well, this is a statewide issue, and it's really a national issue where marijuana or any drug use is concerned. So with alcohol, we have what we call, a limit of, or a maximum amount is 0.08 blood alcohol content, and you're presumed to be under the influence of alcohol, to be impaired. No such standard exists for other drugs, including marijuana. So if somebody's suspected of driving under the influence, and alcohol isn't the factor, then it relies upon the officer's evaluation of the field sobriety tests to show impairment. And that, of course, is the opinion of the officer based on his training and experience. We do have, and the state is ramping up, as other states are, with what we call DREs, drug recognition experts, who are expert in detecting drug use, and I am not a DRE. I know a little bit about it to know there's a lot of different symptomology that they look at and use to evaluate. Again, it comes down to the officer's opinion at the end and conclusion of the examination. So that tells you that when you try to prosecute somebody for driving under the influence, you end up with in alcohol, if you're over 0.08, it's pretty much no questions asked. You broke the law. That's 23152B of the California Vehicle Code. 23152A says you're driving impaired, driving under the influence, but it's not over that 08 limit. So that was, and there's other sections now, I believe, dealing with drug driving, but the deal is you have to prove the impairment. It's not just some measurement. So it's not just, well, there was marijuana in the system, so he must or she must be impaired. So other states are moving towards considering, and some states have it, some level of marijuana in your system, which is a presumed impairment. And I think it's something that has been bannered about in Sacramento. There hasn't been any effective legislation to bring that forward, but I think that's important because otherwise we're going to continue to see these tragedies of either drug driving or multi-substance abuse driving in accidents and other injuries in our communities.
One major concern, we have time for two more questions. The first is one major concern, which was mentioned by all of our speakers about medical marijuana, is the problem of diversion. And just to be clear, diversion means a prescription which is given to one person which is diverted to another. It's a huge problem in our society. All of you have probably heard about OxyContin, about benzodiazepines such as Xanax or Valium or Norco or Vicodin, and the list goes on, that somebody may have, grandma may have a legitimate reason for taking OxyContin because of her pain of her bone from cancer, but her grandchildren are taking that medicine, selling it on the street, or getting high. So that's the issue of diversion. Now, in a Denver substance abuse clinic, according to a recent study last year, 74% of adolescents use someone else's medical marijuana, meaning somebody else was prescribed medical marijuana, and 74% of the adolescents who were admitted for drug abuse were diverting that medicine. So the question is, to those of you who advocate its use, what should we do to prevent diversion?
That is such a difficult problem because it is true and is real. You can have the kids go down to LA, Venice, and get their card, which, by the way, I really have to say it. You corrected yourself once on that, Dr. Hornstein, but these are not prescriptions ever because it's not a drug. It doesn't have for the same reasons Dr. Snow said, it doesn't have a milligram, it doesn't have how much you use, what you use it for. So these are approvals or recommendations. So oftentimes, in many places, they bring them down the little cards, and so do you have your card? But really it's supposed to be, do you have your recommendation? Okay, so many kids can go down there, they bring this stuff back, and there is a lineup in their car on the street at lunchtime outside of the high school and the middle school. And it is such a problem, and I don't know how to deal with it. Because until you get the docs to collaborate and be part of the solution, which is to belong to a cannabinoid, to the AACM, or the Society for Cannabis Clinicians, who are charged with trying to create some great standards and ethics, they're going to have this problem. And I don't know what to do about it.
Yeah.
I really don't. Actually, I do have an idea.
Oh, okay.
You get it out of the smokable. You make most of, which is the mafia, by the way. You get it into the
Don't add the mafia at the end of the
vaporizers.
night. I mean, it makes me nervous.
Anybody from the mafia
from the
here?
mafia, right?
You get it into the vaporizers.
We'll talk to you afterward, right?
And the coffee beans and the Sativex sprays, and you don't have the kids going behind the barn smoking. That's not fun. That's not cool. So if you move the product away from a smokable product, whether it had THC or not, because THC is a real valuable for certain things, but that's what the kids gravitate for. So you bring that down, the more CBD you put in, it takes away the stoniness. So where's the incentive?
Chief?
So maybe that.
And I agree. I would just add that who's diverting this primarily? Young people. If you're 18 years old, you walk by a dispensary on Venice, along the beach on Venice, on the promenade there, the medical marijuana store and the recommendation facility are right next door to each other. In some cases, they do it purely off of Skype. There's not even a doctor there. It's on the internet. You're 18 years old, you get it. How many 18-year-olds compared to a 40-year-old would make a sound decision considering the concerns about diverting it? So it is really a problem. It's a big problem with prescription drugs too, but at least we can go back and see what doctors have keep much better records of those prescriptions versus the lack of records on recommendations that are occurring at our dispensaries.
I said we had one more question, but I'm going to add one because I know the answer to this. So I've got to feel good. From an ethical point of view, do you really think there's a difference between a physician recommending or prescribing medical marijuana? From an ethical, not legal, point of view.
What's the question?
The answer is no, okay?
What's the difference between...
If a physician recommends or prescribes something, it's the same thing ethically, okay? So I think that's the point. We can make distinctions because it's not a real medicine, but maybe it's a real medicine. But I can tell you from the individuals who were using this, it is being acted as a medicine. So from the ethics of medical marijuana, whether your doctor recommends it or prescribes it or advises it or thinks it's a good idea or winks at you one time or does whatever it is that suggests that you use it, that is confirmation that that doctor is recommending it, and ethically, that doctor is responsible for its benefits, its risks, and any harms that accompany it, ethically speaking. But that's not the last question. So the last question is somewhat controversial, just so we end on kind of a fun note. To all three of our panelists, and it's sort of a yes or no question. Do you believe the medical marijuana movement is simply a backdoor way to legalize recreational use? So they're all pointing at each other. To those of you watching,
All right, I'll step forward and go first. You know, the way that Prop 215 was enacted, and given it was an initiative, and really no good laws ever come out of initiatives, but maybe that's because of the lockup in the legislature, you know, and they can't figure it out, so they let the people vote on it. It's written as a profit center, and people who are going to make money are the ones who are promoting it and putting the money into the campaigns. So what was the question? How you going on?
I don't know, but your answer was very good. You're going in the right direction.
But I do think there is because of the cottage industry and the money-making machine that it is. I think there's quite a bit of legitimacy to saying that there is some strong support that you start with medical marijuana and we legalize marijuana, and it's not based on medical care or really patient care or giving a hoot about curing somebody's ills. It's a profit center, and that is my concern.
Dr. Snow?
Ditto.
Ditto. Good answer. Dr. Peterson?
I would have to say that I think that I don't know of any state of the states that are remaining would ever attempt to get a law passed to decriminalize from the get-go, from 0 to 100%. So I think in those states that are thinking about that, the smart way for that group is to go to the medical and then later the entire community. But the part that that those people who have been really sick, and we're talking good 20, 30 years of historical use without benefit of this of our Compassionate Act, they're not there for that recreational. And I do believe there is a body of people who are terribly ill that have found great solace and continue to push forward as activists for medical use that don't care one whit about it for everybody else. And as a matter of fact, really feel that they're being noisy in the conversation, because as it comes from a medical perspective to a big perspective, the help for them is diminished, because now we're coming on to, as Chief says, the social implications, the political indications, and it's no longer pushing science forward, which it is in the realm of medicine. It is a science, and we're trying to understand it as the drug that it is and the medicine that it is.
Very good.
Ditto.
So, ditto.
That was good.
Ladies and gentlemen, as is our custom at the end of these forums, we give each of our speakers an opportunity to have the final word. So maybe we'll go in reverse order. Chief, then Dr. Snow, then Dr. Peterson. Chief, you have a soapbox for 30 seconds.
And I won't take much more than that. I would just say that it's the Wild West, medical marijuana in California, and even in other states, I think they're seeing the same thing. We need better regulation, we need better science behind it, and we need to find a way to control it and not have it destroy our communities and families.
Okay, all right.
I wish that marijuana had never been Schedule I. I wish that it had been available for research a long time ago, because I do believe it has huge value. But in its current form, I think it's causing a lot of harm while benefiting a minority. A large number of people are abusing it and creating long-term health consequences for themselves, as well as emotional problems for our society.
Dr. Peterson.
Wow. I don't even know where to start. 30 seconds. I do believe that there is harm in a certain subset, and those are the adolescents when they start early. I don't know of anybody who has, I really don't agree with the idea that there's harm involved in patients really of almost the common age in my practice, which are midlife to older people. They are almost always getting benefit, and if they don't get benefit, they don't use it. They don't use it. So I'm digressing, and I want to get on track. Tell me.
No, you're good.
Everybody,
she's going good.
I wanted to say here. No.
We'll get back to you. You still have 15 seconds.
It was good.
It was good. It was very good. Ladies and gentlemen, before Dr. Peterson regains her consciousness, we will, I'd like to have you join me in thanking our very professional and frankly brave panelists for being here tonight. Furthermore, just in one quick second, I think we can leave here tonight. I'd like to make a couple of consensus as we all leave this heated discussion today. Number one, I think we can all agree that it is very good for our community to have these kind of public discussions. And I would very, very, very much like to thank the Community Memorial Health System for hosting the Ethics of Caring series. And thank you again to the individuals who helped to put this on. Number two, I think we can come to a consensus that we do need better quality research so that the question of medical marijuana can be answered like any other medical question, with scientific data, with controlled studies, and with the ability of physicians to make a recommendation and treatment prescription for people who need that particular drug. And finally, I think, although there may be some disagreement, I think we should come to a consensus that our country would do well to move medical marijuana from a Schedule I to a Schedule II drug, and that I encourage us. That presupposes nothing. That presupposes simply that we get better research. And better research for physicians and for the community is really what we're striving for. Friends, I'd like to close tonight again by encouraging you to contact Community Memorial Health System. You can do that by CMHS Health, which is their website, cmhshealth.org. We will be continuing this series next year in 2015, I'm delighted to say, or at least I was before this series started today. We do have several very exciting programs which I think will be coming up in 2015. One of them, frankly, will pay respect to a fellow Californian, Brittany Maynard, who, of course, was that 29-year-old woman from California who moved to Oregon approximately a month ago because of an incurable cancer and who sadly killed herself 1 week ago. And the issue we will be discussing, moving from the controversial to perhaps the more controversial, is should physicians in California be allowed to assist suicide for their terminally ill patients? So stay tuned. Please be in touch with Community Memorial Health System. And on behalf of Community Memorial Health System, our panelists, I hope everyone a very happy and safe holiday season, and see you in 2015.